عليكم. بسم الله الرحمن الرحيم. Thank you all for attending our satellite symposium. My name is Mfaddal Aithan, and I am the Senior Immunology Medical Director for Eli Lilly. And I only have one disclosure to tell you, is that I work at Lilly, so obviously. So we're going to go over the baricitinib data. And I want to go over it in a little bit untraditional way. So the data really go in the clinical trials that involve over 3,700 patients in multiple countries around the world. And that's very nice to understand the efficacy of baricitinib in patients, in a standardized patient with RA. And as you can see, we do have efficacy data, whether the treatment or the patient was treatment naive or CSD-MARD inadequate responder or biologic failure patient that even included multiple biologic failures. So that's very nice, but that is not enough to know about the medication and the practice in the clinic. So we do have real-world evidence data that really gives us the effectiveness of the medication in the real world. So does it match the RCT efficacy, or is it under or over the efficacy reported in the RCTs? And we do have about 250,000 patients around the world with these data. So we do have multiple registries that inform us onto the safety and efficacy of baricitinib. And interestingly, Saudi Arabia is involved into one of these studies or registry studies. So we do have about 25 registries that involve more than 6,700 patients, and it does inform us about the efficacy as well as the safety for patients and the dosage and the treatment preferences. So when we look at the red graphs, we do see results from the RCT data, and we do see the efficacy from an RCT perspective, and the orange graphs are the real-world data. So we see the effectiveness of real-world data in baricitinib supersedes those reported from the RCTs, and we do have 7 to 8 out of each 10 patients entering remission or low disease activity in the real world on baricitinib therapy at 6 months. So if we go over one of the cohorts or registries, which is an Italian data about patients on baricitinib, we see reduction of their DAS28 scores from baseline to up to 6 months, as well as CDAI and SDAI. And it's a very good thing that we look at CDAI always, so we don't have any lab interference with our assessment. So whether the patients were biologic naive or inadequate responders, we do see a significant response from baseline to 12 months in this Italian prospective study, and we do see remission rates that are very good as described otherwise. So this is very good, but the short-term data are not sufficient for a chronic disease. So the next question is, what's the trajectory if we keep patients on therapy for years and years in time? So we want to discover the maintenance of efficacy. We want to discover that monotherapy is available as an option. And we want to know that dose titration up and down, does it work or not for the patients that would like to reduce the dose after they've achieved remission, and treatment interruptions, whether they flare the disease or not. So this is from patients who were basically DMARD inadequate responders that started baricitinib therapy. And we do see that once they enter into remission or low disease activity at 6 months, not only they maintain it, but they have a positive trajectory in time, and this goes up to 7 years. So that's a very positive treatment response curve over time. And we do see that even if we look at the DAS28, ESR, and CRP, and we do see that 5 to 6 out of each 10 patients, or 6 out of each 10 patients, will enter into remission and keep it for 7 years at least if they were CSD-MARD inadequate responders, and along with that is the improvement in the functional status. So what about patients that were biologic inadequate responders? And this included patients who even failed 2 or 3 biologics and more. So we do see again a positive trajectory once they enter into low disease activity or remission. At 6 months, they do maintain it for almost 7 years, and we do see that in DAS28 that 5 out of each 10 patients of these treatment-resistant patients otherwise entering into remission and keeping it for almost 7 years. And along with that is the functional HAQ-DI, or the functional status, which is very important. So the same figures give or take are reported from registries in Germany, UK, and Spain, and that is consistent with up to 7 out of each 10 patients entering remission or low disease activity. So we're not seeing that there is an efficacy effectiveness gap, but it's actually the effectiveness in the real world is likely to be higher than what was reported in the RCT program. So the next question is, the EULAR recommends, and this is, I think, last year they recommended to taper and stop steroids and also taper biologics or TSD mods once a patient is in remission. And the only JAK inhibitor that has 2 approved doses is baricitinib. So you can titrate up and down according to the patient's response and needs. So if you titrate down, are you going to maintain remission? Where the data from our studies suggest that up to 80% of the patients are likely to maintain their response if you do titrate down to 2 milligrams from the 4 milligrams. So that's about the efficacy. Now, next is the spicy topic, and I like spicy things. So the spicy topic about JAK inhibitors is basically the safety. So the safety of a JAK inhibitor is a very interesting or a hot topic nowadays, and we see that patients who were on baricitinib that were followed for more than 9 years and have a safety reported in this all-bari-RA study. And interestingly, that more than 62% were above the age of 50, and more than half the patients had at least 1 or more cardiovascular risk factors. And we see a split of 80-20 almost in their baricitinib dosing between 4 and 2 milligrams. So in this group of patients, we see that malignancy happened in less than 1 incident per 100 patient years, and MACE and VTEs happened around 0.5 incidents per 100 patients years. And we know that these outcomes are time dependent, so it makes full sense to express them in 100 patient years sort of results. So what's the safety from the real world evidence? Does it match? Is it better? Is it worse than what was reported from RCTs? And again, I remind you of the baricitinib real world evidence program. And we see that cohorts with large number of patients do report less than 1 incident per 100 patient years of VTEs. And I want to zoom into the Japanese trial, because Japanese trial contains or involved more than 4,700 patients. So that's a very good size or sample size for patients with RA. And not only that, but as you know, Japan has got a population that is aging. And we see that 55% of the patients are above 65 years of age. And 20% of them were even above 75 years of age. And we see that disease duration was in the 11 years range. And we see that there were like 70% or so that were biologic inadequate responders, and around 19% were even other JAKs inadequate responders. So they were not the simplest RA, to say the least. So in this group of patients, we see that the MACE events happened at less than 0.5 incidents per 100 patient years, and the malignancy rates were less than 1 incident per 100 patient years, which is not only consistent with what we know, but it's also lying within the known values or expected for patients or known cohorts for RA. So that is within the expected range of cohorts with RA. So how likely the drug is to survive is a very important question, because when you treat a chronic disease, you don't only treat today and tomorrow, but you treat for a very long time. And we see that from a Swedish registry that baricitinib had better survival when we compare it to other JAKs as well as other biologics, with the only exception that is being rituximab. So now one of the trendy topics nowadays is how much am I going to spend to treat a patient, or the cost efficacy. Now, when we think intuitively about cost efficacy, we tend to think that a cheaper medication is a more cost-effective medication, but that really undermines the second part of the equation, which is efficacy. So you have efficacy on one hand, cost on the other hand, and the real question is how much am I going to spend to achieve a response, not how much am I going to spend per medication. So if we look at the patients with RA, and if you only look at prescriptions, patients who achieve remission cost more at first, second, and third year, but that's a very tunnel vision of looking at things. Because when you zoom out, you look at the overall healthcare bill. If you don't achieve remission, you're going to spend more on patients, and that includes joint replacements, cardiovascular treatments, IV infusions, hospital visits, so many things that you don't capture when you only look at the treatment of RA. So to save on the healthcare bill, you need to get remission. So the next thing I'm going to talk about is pain, and pain is very important for the patients. In fact, it is one of the psychological distressors, one of the things that impair the physical function and decrease the quality of life for patients with RA. And interestingly, here physicians and patients do differ quite a lot. Physicians tend to look at swollen joints for activity, whereas patients tend to look at pain for activity, and that's a very interesting split, because in the real world, even patients that achieve remission do have some remnant noticeable pain, and that is not something that we can easily dismiss. So the question is, do we have a treatment that has an impact on pain? And this data comes from our BEAM study, or RA BEAM study, and we see that baricitinib achieved higher pain control compared to adalimumab, and not only was this achievable at 4 weeks, but the more time you spend, the more likely you're to gain significantly, and it did achieve that quickly, even on the higher end pain measures, or at 50–70% reduction of pain was achieved better and faster by baricitinib compared to adalimumab. Next is, if we fail everything, are we still going to have a pain reduction? And interestingly, that baricitinib, whether it controls or does not control inflammation, it does reduce the pain consistently. So that leads us to the conclusion that there is a direct effect on pain for baricitinib, and this direct effect on pain is rather quite a big one compared to the other biologics. So next I'm going to introduce the concept that we spoke about earlier, and I would like to give you an example, is that if you buy a medication for a single dollar for 10 patients, then you spend $10, but if you get the response in one, then you spend $10 to get one response. And if you buy it for $2, 10 patients, you get response in 5. You paid $20, but you paid 4 per responder. So it's not only the direct cost, is how much you pay per responder. And this shows that JAK inhibitors were actually cost effective when you compare it to TNF inhibitors in achieving a response. So you're likely to reduce the cost on a larger scale if you endorse JAK inhibitors. So safety again, and we see that integrated safety from all the indications for baricitinib, and we see the longest and the largest experience with RA being the first indication. And we see that if you see the patients painted in red, these are the patients with events compared to all the overall pictures, the patients without events. Now you're likely to see that when put in context, this is a very small risk of MACE, and this is a very small risk of VTEs and malignancy and non-melanoma skin cancer. And the good question that comes every once in a while is that when patients or physicians ask, if I treat patients for longer, am I more likely to see adverse events, or are they more cumulative with time? And the question or the answer comes from our All-Bari RA program. And if you compare the incidence at 5 years, 6, 7, and 8, and then 9 years, you see that a stable, low rate of incidence of adverse events happening over time, and this is true for infections, malignancies, MACE, and VTEs. In other words, they remain stable over time. So that was my time. This is the product label for Alimient. Thank you very much.